Okay, Bismillah ar-Rahman ar-Rahim. Are we on? Okay, Bismillah ar-Rahman ar-Rahim. Are we on now? Okay, so hopefully we are online. Okay, guys. Assalamu alaikum wa rahmatullahi wa barakatuh. We are going to start now with this session. This is our first neurology session, and we are going to start with the common infections. Actually, infections are high topics in the exam, either MRCP part 1 or MRCP part 2. In this session, I hope we can cover the most common infections which are seen in the exam. As you know, so I hope we are online. Okay, so we continue. Okay, the common infections encountered in the exam and of course in real life practice include the meningitis, encephalitis, and we may have also a combination of both, meningoencephalitis. We may have a kind of local disease, a brain abscess. Also, we are going to cover some of the HIV related infections, either bacterial infections or TB or fungal infections or viral infections. Also spirochetal infections including syphilis and Lyme disease. We are going to have a special focus on Lyme disease caused by Prolia, and also we just will mention the infections caused by drug abuse. Also, we are going to cover the viral, common viral infections. We have direct effect by the virus, and we have indirect effect as a result of the virus. And we have also the fungal and protozoal infection. Of course, when you see a question in the exam, it will be very clear if the situation is meningitis or encephalitis or meningoencephalitis. So usually if the patient is coming with acute symptoms within a few days with headache, vomiting, and neck stiffness, photophobia, and you may have also some depressed level of consciousness. So this is a scenario of meningitis. If you have associated other manifestations like seizures, for example, or reduced Glasgow Coma Scale, so mostly you have also associated encephalitis. So it's a combination of meningoencephalitis. Sometimes you don't have any signs of meningeal irritation, so no neck stiffness and no photophobia, but you have signs of encephalitis, which include headache, really severe headache and vomiting, reduced conscious levels, and seizures. And this occurs over a period of days. Of course, sometimes the symptoms develop over weeks. So we call it a subacute, and in this condition we have to consider, of course, tuberculous or fungal infections like cryptococcal infections. So if the symptoms are subacute, we may need to consider such infections like TB, like cryptococcal, sometimes also like some forms of limbic encephalitis. We are going to discuss this, and also Some forms of what we call aseptic meningitis also present in a subacute way. Okay, brain abscess usually, the brain abscess usually will have in the scenario, so a patient coming with focal neurological signs, usually we may have a focal neurological deficit, so like weakness, like sensory or motor deficit. Usually you will have a history of convulsions, so the patient may present with seizures, and also a depressed conscious level, and of course you will have a high fever usually seen in the scenario. Usually there is a predisposing factor mentioned in the scenario, like a history of sinusitis, a history of otitis media, or a history of mastoiditis. So we have this history, and in addition to convulsion and depressed conscious level. So first you have to think in brain abscess. Of course, Lyme disease, there are many clues in the history in the patient presenting with a Lyme disease. So Lyme disease can present with cranial nerve affection, especially seventh nerve palsy, so maybe unilateral or bilateral seventh cranial nerve palsy, or it can present also with a picture of meningoencephalitis. Usually there is a typical history, like a history of, for example, we may have a history of camping, and also usually there is a history of rash, the erythema migrans rash, and also I think there may be associated symptoms like arthralgia. These are usually the clues. So the presence of history of rash, or presence of history of arthralgia, and camping. The drug abusers, usually the common infections can be seen in the drug abusers directly, like patients with botulism, and also can tetanus. Indirectly, when you see the drug abuser in the scenario, immediately you have to think in some infections. These may include HIV, or may include hepatitis C virus. Okay, so let's move. So meningitis, as I said, meningitis is a very common scenario in the exam, and of course you will see these cases in the emergency department very frequently. So the scenario of meningitis usually is clear. So the diagnosis commonly is clear, that the patient is coming with meningeal symptoms, including neck stiffness, including photophobia, including headache, vomiting, fever, and there may be also some depressed conscious level as an indicator of increase in the intracranial pressure. So if a patient with meningitis, clinical features of meningitis presenting with these symptoms over days, for example, or subacutely over weeks, in addition to presence of focal neurological signs or depressed conscious level. What we mean by depressed conscious level, we mean a Glasgow Coma scale below 9, or a reduced Glasgow Coma scale from the baseline by 3. So the patient presented with a scale of 12, and now it is 9, or it's 8. So that means we have a depressed conscious level. So of course we know the common signs of meningism, Kernig sign and Brudzinski sign, and you may also provided with these signs in the scenario. So usually you will have a fever, headache, confusion, neck stiffness, photophobia. These are the classical signs of meningitis, or classical presentations. And also you have a signs of meningism you have to elicit, like Kernig sign or Brudzinski sign. There are some specific signs you may be provided in the scenario. So if you have been provided with a rash, that means it's a non-blanching rash on the limbs. So the scenario, if you have been provided with this vasculitis rash, so that points to presence of meningococcal meningitis, and evidence maybe we have a meningococcal septicemia. Okay. Also, if you have a shock, and so the blood pressure of the patient is very low, systolic blood pressure below 90, or the diastolic blood pressure is below 60, and the patient is shocked with peripheral coldness and oliguria, confused. So all signs of shock, you have to think in meningococcal septicemia. But also you have to think in the adrenal signs. The adrenal sign, because meningococcal septicemia may lead to hemorrhage in the adrenal gland. So if you have been provided in the scenario with some lab tests, including blood sugar, where there is a hypoglycemia, hypotension, and hyponatremia, so you have to think in hemorrhage in the adrenal glands, or what we call Waterhouse-Friderichsen syndrome. So you have to check for these. If you have been provided with signs of high intracranial pressure, so that means you have to think immediately in the presence of some underlying etiologies, like cryptococcal meningitis, maybe tuberculous meningitis also, which may show a high intracranial pressure. What is the implication of these signs? Like we said, a reduced conscious level, a Glasgow Coma scale below 9, or reduced by more than 3 from the baseline, or the pupil shows a poor reactivity to light, or it's dilated pupil, or there may be some papilledema, or any focal neurological signs, and if there is there's some hypertension and relative bradycardia. So if you have bradycardia, dilated pupil, or papilledema, or some reduction in the conscious level, in the context of meningitis, this means that you have also an evidence of high intracranial pressure. And if you have any of these, actually you need at least to do a CT brain before doing any lumbar puncture. So going directly for lumbar puncture in these patients may be unwise. So if you have been provided in this scenario by any evidence of reduction in the conscious level, and you will be asked what is the first initial investigation for this patient, of course you have to go for CT brain. If you have evidence of papilledema, or you have evidence of reduced conscious level, because doing lumbar puncture in these patients is very dangerous and may lead to brainstem herniation. Okay, so go for a CT scan, also to exclude any evidence of any space occupying lesions. So whenever you have any evidence of increased intracranial pressure, your initial investigation will to do a CT scan, and not to do a lumbar puncture in these patients. So these are, as I said, meningitis is a common topic in the exam, and we need to clarify the most important scenarios, or the most important issues you may encounter in the exam, and of course in real life practice. Okay, so when the scenario is clear, it is meningitis. So you will ask yourself some questions. It is acute meningitis, or it's acute scenario, so we speak about days, or subacute, that means we speak about weeks. If it's subacute, so you have to think in fungal and tuberculous. So if it's acute, so usually we speak about bacterial or viral. And if it's bacterial, which one? Is it a gram-positive cocci, gram-positive bacilli, gram-negative cocci, gram-negative bacilli? So I have to think what is the possible etiology. And you will see many organisms can be involved in causing meningitis, either bacterial or viral. If it's viral, which one? Of course, we have common viruses which cause viral meningitis, but sometimes we need to confirm some specific viral etiologies. Also, we have to think when to suspect a fungal infection. Specific interest in MRCP exam on Cryptococcus neoformans infection. Some meningitis cases may be non-infectious, so like what we call Carcinomatous meningitis, and from its name it's related to the presence of some cancer, so like lymphoma, like breast cancer, like lung cancer. So if you have been given a scenario of meningitis, of patient presenting with symptoms and signs compatible with meningitis in the context of a history of breast cancer or lung cancer or lymphoma, so you have to think in this differential diagnosis, carcinomatous meningitis. Aseptic meningitis also is an important topic and sometimes also appear in the exam, and we are going to cover this very shortly. Of course, when you will be asked, or most of the questions may stress on the treatment, either empirical treatment or the specific treatment or some supportive therapies, and also in chemo prophylaxis for meningitis. So you may be given a scenario of meningitis and a picture of CSF, which and you will be asked about the best initial treatment in this patient. So you have to be aware of this scenario. Okay, so let's move on. So in most of the scenarios of meningitis, you will be provided by a CSF picture. So I don't want you to save all these numbers. Usually in the exam you will be provided with the normal parameters, normal numbers, and the patient numbers. I want you to stress on some data because usually the data given, and I always say when you are giving some data in the scenario, stress in all of these data, because every single word, every single number usually means something in the scenario, and it's not given just haphazardly. Okay, so for example, if you're given regarding the pressure, so the opening pressure for the CSF, you may be provided by this, and usually the pressure, if it's very high, what do we mean by very high? Means that it's 40 or above. You almost always this is a fungal infection. Okay, so if the pressure is very high, you may think in two things: either this is a fungal infection, cryptococcal infection, or maybe tuberculosis. And tuberculosis, usually the pressure does not go that high. So if you find it's above 40, usually this is a fungal infection or cryptococcal infection, almost always like this. And if it's just high, so it's something 30 or 25 to 30, usually this is a kind of tuberculosis. And we will speak about how to differentiate. Of course, in the viral infection, the CSF, the appearances will be clear, and it will be turbid in the bacterial infections. This is, of course, it's clear. Regarding the protein glucose, and cells, because usually these are the common three parameters. You will reach the diagnosis based on these three parameters. So in bacterial, in tuberculous, and fungal, the protein is increased, is much high, especially especially in tuberculous infections. Of course, also the protein is high in some cases of aseptic meningitis, and also in patients with carcinomatous meningitis. But commonly, we speak now mainly on the infections, bacterial, viral, or fungal. So a high level of protein usually indicates significant, especially if above 1 gram, usually indicates some form of bacterial or tuberculous infections. If you find that the glucose is very low, that means usually you are encountered with a bacterial or tuberculous infection or TB. Okay. Of course, you will differentiate. How you will differentiate? By the pressures and by the type of cells. In TB, in fungal, it's a lymphocytic CSF, and in bacterial, you really find it's a polymorph nucleoside or maybe neutrophilic infection, unless the patient was given any prior antibiotic, and usually you will see this in the scenario. So if you see in the scenario that the patient received antibiotic for whatever the reason, so maybe he has experienced some sinusitis and he was given antibiotic, of course you may see lymphocytes in the CSF of a patient with bacterial infection. So that's a partially treated patient, and it may show a lymphocytic CSF in spite of being bacterial infection and not neutrophils. Okay, so a very low glucose you need to think in TB and fungal. It's moderately reduced glucose you think in bacterial. So high protein, low glucose, and lymphocytes. Think in TB or fungal infection. High protein, low glucose, and neutrophils think in bacterial infection. In viral infection, all the parameters usually may be borderline. So the protein may be normal, just minimally elevated, and glucose usually within normal, and usually the cells also are lymphocytic, mainly lymphocyte cells. So it's a lymphocytic CSF. So usually, you can say it's a bit confusing, but generally you have to look to all of these parameters rapidly. If you have been provided with a very high pressure, so fungal or tuberculous, a very low glucose, it's TB or fungal. So okay, it's like this. It's a lymphocytic. So TB and fungal, viral. If maybe still maybe bacterial, if there is a partial treatment or the patient was given any antibiotics. Okay, so let's move on. So usually from looking to the CSF parameters, you will know which kind of meningitis you are dealing with. Aseptic meningitis, from its name, it's aseptic, and there are many causes for aseptic meningitis, but you have to stress on 3 common causes, and usually the scenario will be clear. Usually the fever, usually there is no fever, okay, or a very low grade fever, and the CSF would be lymphocytic. Okay, so it's a lymphocytic CSF, almost no fever, and from its name, it's just a meningitis which shows a negative cultures for bacteria or fungus. So repeated cultures and repeated samples is always negative, and no fever, and it's lymphocytic. So this is a scenario of aseptic meningitis. The most common causes you need to know. First, partially treated, so partial antibiotic therapy before doing the lumbar puncture. Make it this picture. The second is viral, so most common cause of causing such form of lymphocytic and just viral, like maybe like Coxsackie virus or like some viruses like I think which the ecovirus, yes. Carcinomatous meningitis scenario, from its name, it's meningitis, it's no fever usually, okay, and related to some cancer, as I said, lymphoma, usually the history of breast cancer or lung cancer. And you need to think in this scenario, if we have been provided with a scenario of meningitis, it's a so usually it's a patient presenting with these symptoms over months. So it's a long-term presentation, it's not just acute presentation. And also you will see that the associated manifestations, it seems like unrelated. So you will find some cranial nerve affection, you will find some cerebral affection, so meningitis, evidence of cerebral and so focal neurological signs, and evidence of meningitis, and multiple cranial nerves, and at the same time you will see some evidence of spinal cord affection. So you may see like evidence of coda equina, so some paresthesias in the very inner regions, and lost reflexes in the lower limbs, and weakness, and also maybe in the form of sciatica. So spinal cord affections and meningeal affections and brain affections, so some form of like seizures, for example, or focal neurological sign, so, and the cranial nerve affection. So everything is affected in the presence of meningitis and history of cancer. That refers to carcinomatous meningitis. Usually this scenario is a bit clear, and CSF is a lymphocytic meningitis. Okay. So don't forget aseptic meningitis. If you have been given in this scenario, the patient already received some antibiotic therapy, or the patient received some drugs. If the patient is receiving some drugs, it may cause a form of aseptic meningitis. The most common drugs or the most common medications that may cause this include IV immunoglobulin. So that's one of the scenarios. Maybe given a patient was given IV immunoglobulin due to whatever the cause. So maybe given IV immunoglobulin for Guillain-Barré syndrome, for example. Okay, and in this situation and presenting with signs of meningitis, you have to think in aseptic meningitis, and it's lymphocytic meningitis. Other drugs that may cause this: non-steroidal anti-inflammatory drugs and sulfamethoxazole and trimethoprim. So Septrin, or the combination of sulfa and trimethoprim, or some non-steroidal anti-inflammatory drugs. If there is no history of these drugs and no history of prior antibiotics, and it's no fever and it's lymphocytic meningitis, and you have to think it's viral meningitis, and it causes, and you will see in this scenario that, and you will be given the information like this: repeated cultures revealed a negative for bacteria and fungi. So that means the writer of the question just wants you to know that it's a scenario of aseptic meningitis. The lumbar puncture, as I said before, If the patient shows any evidence of high intracranial pressure, so a reduced conscious level or focal neurological signs, or the pupil is dilated or poorly reactive, or if there is evidence of papilledema, you need to do a CT plan before doing any lumbar puncture. So don't try to do lumbar puncture in these patients at all. You have to exclude any evidence of space occupying lesions or any cause for brain edema. Of course, you have to know that the platelet count is very important. So platelet count below 50,000, don't go for lumbar puncture. So coagulation problem is very important. If the patient is shocked with evidence of shock, so meningococcal septicemia and septic shock, and expanding vasculitis and purpura, don't go for lumbar punctures. If the patient develops convulsions as a part of meningoencephalitis, also don't go for lumbar puncture immediately. Just stabilize the patient and then go on. So the CT brain, as I said, the CT brain is very important in patients showing evidence of high intracranial pressure or depressed conscious level or focal neurological signs before going for any lumbar puncture. Of course, when you see the scenario of a meningitis, and it's clear from the CSF it is bacterial, so a high protein and low glucose, and it's the cellular pattern is of a polymorph nucleosides or neutrophilic, so it's a bacterial meningitis. The next step, which bacteria, which kind of bacteria? Is it meningococci? Is it streptococci? Is it Staph aureus? Is it Staph epidermidis? Listeria monocytes? Of course, the most common bacteria encountered in the exam will be the meningococci or Streptococcus pneumoniae or Listeria monocytogenes. But of course, you have to know when you suspect these other organisms. So meningococci, usually the scenario is if it's a part of an epidemic, for example, in camping, after camping, or if it's a part of an epidemic like in the many patients came after Hajj, so that's a meningococcal infection, and more specifically it's a meningococci serotype A, and or if there is any evidence of vasculitic rash, evidence of purpuric rash, or evidence of septicemia, or evidence of hypoadrenalism, so hypotension, hypoglycemia, and the hyponatremia. So that's a meningococcal infection. So that's most likely organism in this scenario. For example, if the patient presenting after penetrating a head trauma, penetrating a trauma with a meningitis, so you have to think in Staph aureus. If the patient is presenting after neurosurgery, like doing shunt surgery or CSF surgery, so and presented with meningitis, think in Staph epidermidis. Listeria monocytogenes, it's very important to think in this in the young patients or in the elderly. So in the patients above 60 years or the young infants below 3 months, the immunocompromised patients, and those patients who are who are interested in eating the French cheese. So some types of this cheese, of this cheese may predispose to Listeria infections. So the French cheese, so immunocompromised, extremes of age, you have to think in Listeria monocytogenes. This is a gram-positive bacillus. Okay, Streptococcus pneumonia also, if you have been given the scenario that there is a history of upper respiratory tract infection, or evidence of pneumonia, or evidence of otitis media, so think in Streptococcus pneumonia, and this is, of course, a gram-streptococci. So in this scenario, usually you will reach the possible underlying bacterial infection from the scenario. Of course, the enteroviruses like Echo or Coxsackie virus is the most common cause of viral meningitis in UK. So you have to think any evidence of viral meningitis, that's acute form of meningitis, maybe some forms of meningoencephalitis, and CSF is of viral pattern. So fever and evidence of meningitis, the clinical features, classic clinical features of meningitis, and CSF showing evidence of viral infections. So within normal glucose, a minimally elevated protein, and lymphocytic CSF, and negative cultures for bacteria. So it's a viral infection. And what's the most likely cause? It's Coxsackie virus, if you have been given, or ecovirus, any form of the enterovirus, because this is the most common cause. Unless you have an evidence for another reason, like herpes simplex virus infection, which may cause encephalitis or meningoencephalitis. Herpes simplex virus infection can cause meningitis, meningoencephalitis, or commonly present with, and the common scenarios in the exam, these patients present with encephalitis. So patients coming with acute history for days, weeks, with confusion, depressed conscious level, vomiting, maybe some seizures, and because it's commonly affected the temporal lobe, it can present with convulsions, or can present with some oroalimentary automatic behavior, so like lip smacking. So that's quite characteristic, lip smacking in the context of convulsions and depressed conscious level. Presence of lip smacking means the temporal lobe affection commonly due to herpes simplex virus infection. You have to know also, in the era of COVID-19, that some cases of meningoencephalitis have been reported. So if you have been given a scenario suggestive of COVID-19, presence of maybe loss of smell sensation, so there is anosmia, a loss of taste sensations, some forms of fever and cough, and presented with meningoencephalitis, so you have to think in also in COVID-19 in this era. And of course, COVID-19 will be, will be of a high yield topic in the next diet. So don't forget that some cases of COVID-19 may present with meningoencephalitis. Okay. As I said, in cryptococcal, the fungal infection, Cryptococcus neoformans or TB meningitis, they are common in the immunocompromised patients. And the scenario of these two cases usually is similar, but actually some informations, if you read the question carefully, you will reach the diagnosis, and you can easily differentiate. Of course, both cryptococcal or tuberculous meningitis or cryptococcal usually present in an immunocompromised patients. So you will have some underlying cause for such immunocompromise, like taking some immunosuppressive drugs, or the patient is HIV, non-HIV, or you may be given like a risk factor for developing HIV, like homosexuals, or IV drug abuse or something like that. So usually the patient is immunocompromised, whatever the reason. So cryptococcal versus tuberculosis. Both present subacutely over weeks. Usually in the tuberculosis, there may be a history of TB or some cough or loss of weight, night sweats and fever. So some symptoms suggestive of TB. And in cryptococcal infection, also there may be some history of also lung infection. So in both cases, presentation is subacute and immunocompromised, as I said. And in the CSF, both are lymphocytic and both show a high pressure and increased protein and low glucose. Especially with TB, is a very low glucose. Cryptococcal usually shows a high opening pressure, which is, as I said initially, the pressure is usually the opening pressure usually is high, even reaching above 40. So you have to think in cryptococcal if you have a very high opening pressure. Both can show cranial nerve affection, but cryptococcal, because it's associated with high intracranial pressure and maybe some edema on the MRI CT, usually these patients in the cryptococcal meningitis on MRI shows what we call a meningeal enhancement and associated with a false localizing sign of 6 nerve palsy. So cryptococcal, a high opening pressure when doing lumbar puncture, there is evidence of intracranial hypertension, and there is a false localizing sign of a 6 nerve palsy. And in the CSF, it's like TB usually, so it is lymphocytic, elevated protein, and a low glucose. But the main clue for cryptococcal prevention is a very high opening pressure, maybe some 6 nerve palsy. And the tuberculous, you may notice a multiple cranial nerve affection. You may see third nerve, fourth nerve, sixth nerve, and so on. So it's usually it's not a single nerve, and the pressure is not very high, maybe from 20 to 30 centimeter water, the opening pressure for a patient with tuberculous meningitis. Okay. So think in this. Carcinomatous meningitis, already I described this. So it's long-lasting, associated with the history of malignancy, especially breast cancer in a female, or a lung cancer, or lymphoma. And many parts of the nervous system are affected. Spinal cord, maybe sciatica, or like a picture of coda equina. Multiple cranial nerves are affected, and the brain, there is evidence of focal neurological signs or seizures or breast conscious level, and evidence of meningoencephalitis. So you see a bizarre picture: the brain, the cranial nerves, spinal cord, in the context of meningitis. This refer, and maybe a history of cancer, means this is a scenario of carcinomatous and meningitis. Okay. You may find a tumor cell in the CSF, and the treatment, of course, of these patients is by intrathecal chemotherapy. Okay. Okay, so let's move on. Aseptic meningitis, already discussed. So the most common causes are prior antibiotic therapy, and you will see this in the scenario. So it will be a lymphocytic meningitis and negative repeated cultures. Aseptic meningitis, no fever. Drug induced, don't forget this, non-steroidal anti-inflammatory drugs, Septrin, or the combination of sulfamethoxazole and trimethoprim, or the common cause. Of course, it's not a common side effect, but it's reported. The aseptic meningitis related to IV immunoglobulin use. Viral meningitis, so a lymphocytic meningitis, aseptic, negative culture for bacteria and fungal. that is viral. So these are the most common 3 causes for aseptic meningitis: prior antibiotic therapy, some drugs, and viral causes. So you have to think. And the clue for this: evidence of meningitis, classic meningitis, however there is no fever, and the CSF is lymphocytic. If you see a history of the drugs or any prior antibiotic therapy, you have to think in this. Okay, so this is also a common high-yield question: the initial treatment for a patient with suspected meningitis. So you have to think in this. Don't be confused about this slide, because as you see, almost all antibiotics will be mentioned while we are discussing this issue, the meningitis. Almost all antibiotics: penicillins, cephalosporins, quinolones, and aminoglycosides, vancomycins, so, and even rifampicin. So let's just take it just very simple and make it very simple. If you have a patient in the primary care, any patient suspected meningitis, and this is usually asked in the MRCP question exam, you start with benzyl. If you have been given this option, if a patient presenting with the primary care, an adult patient presenting, usually we start with benzyl penicillin in the primary care unit. If the patient is presented to the hospital, to the emergency department, and you will be asked about your best initial treatment, here you have to stop a little bit. Of course, cefotriaxone is can be given as a single drug, or maybe given as a combination with other antibiotics. So if you remember when we spoke about listeria, so French cheese, extremes of age below 3 months age, or elderly or immunocompromised, this patient you have to suspect listeria monocytogenes. Especially if you have some brainstem affection. So if you have some bulbar symptoms like dysarthria or dysphagia in a patient with meningitis, so think in listeria monocytogenes. So if you have such scenario, think in listeria in the presence of high presence of brainstem affection. Okay, so in case of brainstem affection, think in listeria monocytogenes. Okay, the extremes of age. So you will give cefotriaxone plus ampicillin or amoxicillin. Here I want you to notice a point. What's this point? For empirical treatment, when you have a suspicion of listeria monocytogenes, you give ampicillin or amoxicillin plus cefotriaxone or cefotaxime. What is the difference? The difference here, if you don't give cefotriaxone in the preterm babies, so it's below 3 months, and if it's preterm or having or these babies have shown some jaundice, we don't give cefotriaxone and we give cefotaxime. If it's full term and no jaundice, you can still give cefotriaxone. Okay, so usually the classic combination in children below 3 months is ampicillin or garamycin plus cefotaxime. Or if you have been given in the exam a cefotaxime or cefotriaxone, so cefotaxime, that's according to NICE guidelines, cefotaxime plus ampicillin or amoxicillin. If the diagnosis is confirmed, so if you have a confirmed treatment, if the diagnosis already confirmed that it is listeria monocytogenes, so in this situation it is not it is not it's not just empirical treatment. It's now we are going to give a specific treatment. And in this situation, it's ampicillin or ampicillin or amoxicillin plus garamycin. Ampicillin or amoxicillin plus garamycin. Okay. So cefotriaxone is given empirically, or cefotaxime, especially in the preterm or babies with jaundice. Okay. If a meningococcal infection is suspected or above 3 months, so we start with cefotriaxone, and this is by default in an adult patient presenting with a meningitis. The best initial treatment is cefotriaxone, so above 3 months, or if there is, especially if there is evidence of meningococcal infection, so some vasculitis, puerperal crash, or maybe during outbreak, or after camping, after Hajj. So you start with cefotriaxone. Okay. In some cases, we need to add vancomycin to this regimen. So vancomycin plus cefotriaxone if there is a history of prolonged or multiple antibiotic exposure. If the patient previously given multiple antibiotics or prolonged antibiotic exposure and they presented with such meningitis, so you need to add cefotriaxone plus vancomycin. This is according to nice guidance or nice guidelines. So cefotriaxone plus vancomycin. So by default it is cefotriaxone. If there is any suspicion of listeria, cefotriaxone plus amoxicillin or ampicillin. Okay. If it's a preterm baby or the jaundice, cefotaxime plus ampicillin or amoxicillin. If there is a prolonged exposure to antibiotics or use of multiple antibiotics before presentation, we add vancomycin to cefotriaxone. If we have a penetrating head trauma or CSF surgery, usually you need vancomycin to cover for staph aureus. As I said, if CSF of penetrating head trauma, it's usually staph aureus. So cover by vancomycin and ceftazidime to. Okay. If you have a skull fracture base, so usually we add vancomycin to cefotriaxone. So we add vancomycin to cefotriaxone in case of fracture base, the skull, so meningitis after fracture of the skull, or after prolonged or multiple exposure to antibiotic, or after penetrating head trauma. Okay. So suspected listeria, cefotriaxone plus ampicillin or amoxicillin. Confirmed listeria, ampicillin or amoxicillin plus guara or plus gentamicin. Okay. Of course, we are going to think about the duration of treatment. If a viral meningitis from the CSF picture, usually based on on suspicion from CSF and the clinical picture, we start with acyclovir. So whenever you have a picture of viral meningitis, so almost normal protein or minimally elevated protein and normal glucose and lymphocytic, you will start with acyclovir. If you can differentiate if it's bacterial or viral, you start. So if the CSF is inconclusive and doesn't show to anything, you may give also bacteria and cefotriaxone plus acyclovir. For suspected TB, we don't give empirical treatment for TB before confirmations. Chloramphenicol, if you have been given in the history that there is a history of anaphylaxis for penicillins, and of course in this scenario you will not give penicillin or cefotriaxone, you will give a chloramphenicol as an alternative, as an initial treatment for the patients. So that's the only scenario you may give a history of anaphylaxis to penicillin. Not just a history of diarrhea, disease, or history of like skin rash or something. No, history of anaphylaxis. Okay, so just to recap this empirical treatment, you have in the primary care, start with benzyl penicillin. Okay, if you're in the hospital, start with cefotriaxone. If the young baby below 3 months, add ampicillin or amoxicillin to cefotriaxone. If there is or any history suspicious of listeria, so immunosuppressed patient, or French cheese intake, and also you add ampicillin or amoxicillin. So if there is a prolonged or multiple exposure to multiple antibiotics before presentation, add vancomycin. If there is head trauma or CSF surgery, add vancomycin. Okay. It's rarely you will be asked about the duration of treatment of meningitis, but just in short, the treatment of if already there is a positive culture for meningococci, then usually the treatment is for 1 week. Okay, 1 week medications of cefotriaxone. If it's listeria, as I said, you treat with ampicillin or amoxicillin plus garamycin. The treatment of listeria, because it occurs mainly in the immunocompromised patient, it's a bit prolonged. It's a 3-week treatment, and the garamycin only for 1 week. So ampicillin and amoxicillin for 3 weeks, and garamycin for 1 week. Okay. I think this is not a common question, but just it's 1 week treatment, and listeria monocytosis it's a 3 weeks treatment. Okay. However, we give only 1 week of garamycin. I hope this is still, the screen is shared, so still you see the presentation. I hope still you see this. Anyone can confirm? Okay, so hope we confirm this. Regarding the chemoprophylaxis, this is also an important point. It caused a lot of confusion. Okay, we have 3 drugs possibly we can prescribe for chemoprophylaxis. It's prescribed for patients with meningococcal meningitis, so not for all cases, of course. So patients presenting in outbreak, epidemic, in because as I said, it's a very common cause for meningitis. So if the most likely organism would be meningococcal, and this is a gram negative cocci, as I said. So how to choose between ciprofloxacin and cefotriaxone? So usually ciprofloxacin is given to adult patients, so above 18 years old we give ciprofloxacin. It's 500 milligram single dose. That's a chemoprophylaxis for the close contacts in the family usually. So we give 500 milligram single dose. If the patient is younger than 18 years old, so if it's a patient is 16, 15 years old, in this scenario, if you have been asked about the prophylaxis, never to give ciprofloxacin. So ciprofloxacin here will be a big mistake. So for a young patient, 16, 15, so below 18, we give here a single dose of cefotriaxone. Okay, so cefotriaxone single dose usually is a good option for the chemoprophylaxis in patients with meningococcal meningitis. The option of rifampicin is attractive option, especially in the pediatric age. Of course, you have to avoid rifampicin in pregnancy. So avoid ciprofloxacin below 18 years old. Avoid rifampicin if the patient is pregnant. So you may give ceftriaxone. Of course, if a pregnant lady developed the meningitis, so you will never give ciprofloxacin and you will never give rifampicin. You will give here only ceftriaxone. If an adult patient above 18 years old and not pregnant, so by default you will give ciprofloxacin. Okay, so if they're younger than 18, your choice will be ceftriaxone. Hope this is a clear point. Okay. This is just very brief information about meningococci. Meningococci are gram-negative cocci. You have 12 serotypes. Only 6 can cause epidemics: A, B, C, X, Y, W. The common serotype in Hajj, if the scenario from in Hajj, is a meningococci serotype A. Regarding meningococci serotype B, is the cause for about 90% of cases of meningococcal infection in the younger children. So the most common cause of meningococcal is meningococci B. So you may be asked also about this, but the most likely cause meningococci P or A in Hajj-Bailey, and B is the most, especially in a young child. The vaccine of covering 4 serotypes A, C, W, and Y. It's called ACWY vaccine. It's given to patients aged from 13 to 15 years old. So, okay. Regarding use of steroids, usually we give steroids in bacterial meningitis. So if a patient is a clear purulent CSF, we start steroids. It's very important. Or if it is white blood cells above 1,000, okay, or high level of protein. So frankly, purulent CSF or white blood cells above 1,000, usually we start dexamethasone to these patients. Okay, so I don't go into detail. Just give steroid in case of bacterial meningitis, clearly purulent CSF and a high CSF, a high cellular count above 1,000 of white blood cells. In patients with evidence of cryptococcal meningitis from a very high opening pressure and subacute presentation over weeks, and a very low blood glucose, and maybe 6-nerve palsy, we start also an evidence of brain edema. We give steroids also. If there is evidence of adrenal hemorrhage, or what we call Waterhouse-Friderichsen syndrome, if a patient with evidence of meningococcal septicemia, there is a purpuric rash, vasculitis, shocked patient, hypertension, hypoglycemia, and the hyponatremia, we give steroids to these patients. And usually these patients are given dexamethasone 4 doses, or 4 doses daily for 4 days. So the rule of 4 of dexamethasone, best to be given within 4 hours of first antibiotic dose, and it's given usually from about, in the adult patient, from 6 to 10 milligram, or you can, or maybe 8 milligram every 6 hours, and for 4 days. So give 4 doses every day for 4 days. Better to start within 4 hours of the first antibiotic dose. Never to give steroids in the young patient below 3 months. We are going to rapid review encephalitis. So this is the patient presenting without any evidence of meningitis. So no neck stiffness, no photophobia, no evidence of meningitis. So negative signs of meningitis, Brzezinski or Kern sign. So the patient usually presents with severe headache, vomiting, depressed contrast level, and seizures, and these are all evidence of encephalitis. So confusion and decreased contrast level and seizures in a patient with no history of or no evidence of meningitis. That's usually a scenario of encephalitis presenting acutely. Herpes simplex is by far the most common encephalitis seen in the exam. Most common cause is herpes simplex virus type 1, 90% of course, less likely herpes simplex virus type 2. And the most likely part of the brain affected is the temporal lobe, so it's diagnosed by MRI. Early the clinical pictures, and CSF will show a lymphocytic picture with usually near normal protein and near normal glucose. So it's diagnosed by the best test, of course, the MRI, and best diagnosed and confirmation by BCR of CSF for herpes simplex virus, and its treatment is by initial treatment by herpes by acyclovir. So usually 2 weeks of IV acyclovir is needed. So this is a classic picture, MRI picture of patients with herpes simplex virus encephalitis. Cytomegalovirus encephalitis usually will be in the scenario of HIV patient with a very low CD4